Welcome back, everyone. We are very fortunate to have this incredible panel of neuroendocrine cancer experts join us for a live question and answer session. It's an honor to introduce today's panelists. In alphabetical order, Dr. Jennifer Chan, medical oncologist from Dana-Farber Cancer Institute in Boston, Massachusetts, Dr. Chandrikha Chandrasekharan, medical oncologist from MD Anderson in Houston, Texas, Dr. Delphine Chen, nuclear medicine physician from Fred Hutch Cancer Center in Seattle, Washington, Dr. Jaydira Del Rivero, medical oncologist and endocrinologist from the National Cancer Institute, National Institute of Health in Bethesda, Maryland, Dr. Udhayvir Grewal, medical oncologist from Emory Winship Cancer Institute, Dr. Thor Halfdanarson from Mayo Clinic in Rochester, Minnesota, Dr. Pamela Kunz from Yale Cancer Center and Smilow Cancer Hospital, Dr. Michael Soulen, interventional radiologist from Penn Medicine in Philadelphia, Pennsylvania, and Dr. Jason Starr, medical oncologist from Mayo Clinic in Jacksonville, Florida. And of course, Josh Mailman, president of NorCal Carcinoid and patient advocate extraordinaire, who will be serving as co-moderator for today's Q&A session. 90 minutes for the entire Q&A session, divided into two parts. I will moderate the first part of the Q&A session with Drs. Chandrasekharan, Chen, Del Rivero, Kunz, and Starr. And Josh will moderate the second parts with Drs. Chan, Grewal, Halfdanarson, and Soulen. I invite the first group to stay on with me while Josh and the second group can now turn off their cameras. And a reminder to the audience, this Q&A is for educational purposes only and should not be taken as medical advice. We encourage you to speak to your own medical provider about your specific situation. And we will now try to get to as many broad-based questions as possible. We'll go to the first question now. Dr. Kunz, we'll start with you. Are NETs considered cancer?
Hi, Lisa, and hi, everybody. Thanks so much. That's a great question. And actually, this came up in clinic this week for me. So I think it's probably relevant for lots of our listeners. So the short answer is yes, NETs are considered cancer. I think the confusion has arisen given the complicated terminology over many decades. Some of you may have heard of the term carcinoid, which means cancer-like. This was a term that was coined in the early 1900s when, in fact, these cancers were not thought to be able to spread or metastasize. And so there was a lot of confusion around that. We now know, in fact, that NETs can grow, can spread to other places. We just don't know which ones might do that. And so we think of these all as cancers. Patients are treated with cancer-directed therapies. Some may have a higher likelihood of spreading or growing than others, but I think the right way to think about these are in fact cancers and we have to treat them as such.
Thank you so much. Dr. Del Rivero, Dr. Kunz just mentioned carcinoid and how that was an old term. What is the understanding about the hormonal or emotional symptoms of carcinoid syndrome? Do you have any suggestions around this?
Great. Thank you, Lisa and everyone, and for being here today. And I do think it's an important question to understand the emotional aspect as well around any cancer diagnosis. I think in the setting of neuroendocrine tumors, I think it's important to understand symptoms related to hormone excess, but also how having the diagnosis and the symptoms related to hormone excess may impact the emotional aspects of anyone, not only for patients, but the same for caregivers too. In terms of the hormone related to, or the symptoms related to hormone excess, I think, for example, in the setting of carcinoid syndrome, so how it happened is that tryptophan is an essential amino acid. It is in everything that we eat and a lot of the food that we eat. And that tryptophan is then, in the center of having a neuroendocrine tumors, that tryptophan converts into serotonin and then subsequently into the urine via 5-HIAA. So the tryptophan is used a lot in this situation. And some patients, they get depleted in other parts. And being an essential amino acid is important in certain aspects of functionalities of the body, like, for example, sleep. Tryptophan is important for melatonin. So that's an aspect that sometimes patients may also discuss, that having the lack of sleep is one of those aspects. For example, tryptophan, there has been also studies that tryptophan also, the low tryptophan correlates with higher levels of cortisol. So cortisol is an important hormone, is considered a stress hormone. think there's different aspects between the emotional and as well as having the diagnosis of the tumor, of the neuroendocrine tumor, as well how the excess of hormones has the implications in the symptoms and how these symptoms can enhance some aspects of the emotional well-being. I think in these situations, two important parts is to, consult with someone who has an expertise in neuroendocrine tumors. But the other aspect as well is that having a good support system too, to help understand, all the different aspects of how this can impact well-being. And with that, I was, having support groups, and as well, educate patients themselves. Also, consult with palliative. I think palliative is one aspect that we always feel that is the end of life, but that's not necessarily the case, right? Palliative is help patients to live their best life, having and living with this diagnosis. And I think all of that is important so that way we can manage appropriately not only the symptoms related to hormone excess that can cause some emotional aspects and enhance some emotional aspects of the well-being, but at the same time having a good support system that can help you overcome all those aspects. I don't know if anybody has any opinion.
Yeah. Dr. Del Rivero, I really appreciate how thorough and how holistic that answer was. That was very informative. I'm going to follow up with Dr. Starr. There was a question specifically about tryptophan diet. How do I know if I should follow a low tryptophan diet? I've received contradictory information about this and my nutritional needs.
Yeah, so this kind of dovetails with Dr. Del Rivero's kind of explanation with that last question. So tryptophan is a precursor for serotonin. So in a patient who has a neuroendocrine tumor that's what we call hormonally active, the body will divert more tryptophan to serotonin, right? So you could experience more carcinoid syndrome type symptoms, i.e. diarrhea. Flushing is a bit more complicated. So it's not necessarily tryptophan, but we call these substances amines. Serotonin is an amine. Histamine is an amine, right? So there's a lot of different substances in the body that have these precursors that when you eat foods that have the precursors, it could make a surge in hormones go up. So this is what I tell patients. If you eat a food and it seems to trigger certain symptoms, or you drink alcohol, it seems to trigger your symptoms, don't eat that or don't drink that, right? But I don't think you need to avoid foods if you don't have the symptoms. And I think that's where a little bit of the kind of misinformation comes in. It's like, oh, I have neuroendocrine tumor, I shouldn't eat these foods. Those foods are not going to hurt you. But if the foods trigger symptoms due to the mechanism that I had mentioned, then you should have some avoidance there. I always am cautious there because food is part of life, part of the enjoyment of life. So I hate to eliminate foods that people enjoy because I think that's, quality of life kind of, something that contributes to quality of life. So that's how I kind of counsel patients on that.
Thank you so much. Quality of life matters for sure. I'd like to ask Dr. Chen about some scan questions that came up. What's the best non-MRI scan to evaluate bone pain? And then secondly, if there are bone lesions detected, what imaging technique like nuclear medicine, gamma, MR, or CT is best to reveal the detail of the bone lesions that are detected previously on scans like MRI or PET scans?
Yeah, thanks for the question. Actually, one of the general nuclear medicine studies that we use a lot for other cancers is a bone scan. So bone scans are really good at showing bone metastases when that bone metastasis is causing the bone cells around it to react to it and deposit calcium. We call those sclerotic lesions. So I don't know if you recall in my talk, one of the CT pictures shows those bone lesions really well as white spots. That means the bone is depositing calcium because the bone is trying to react and it's reacting to what the tumor is doing to the bone matrix. So when it has that kind of reaction, you can see them on a bone scan, and we can use them really well to follow bone tumor metastases in other cancer types. We can also use it for looking at sites of bone pain, for example, in patients with compression fractures, if they're trying to look at whether there's movement in the compression fracture before they intervene to try to reduce that bone pain. So bone scans are a nice alternative modality. If you cannot get an MRI and you're trying to find the source of bone pain, it will at least show those where you have that sclerotic reaction or that calcium depositing feature of the bone metastasis. If it doesn't, if it has what's called a lytic appearance, which is the tumor is actually eating away at the bone matrix and it's not able to deposit calcium around it, then even the CT will show that lytic metastasis pretty well, and that's probably the best way to characterize it. And then depending on where it is, like if it's in your long bones, basically your arms and legs, plain radiographs actually might be the best way to look at whether you're at an increased risk for fracture per se. And then with regard to, and this leads me into your other question of what other modalities are available to characterize bone metastases, it really depends on why you're trying to characterize the bone metastasis. For general staging, as I mentioned, between Dotatate PET, CT, and MRI, depending on which shows it the best, you might want to use that for following it. But if you're worried about, again, specific bone pain sites, that's where we start looking at, CT and MRI show those lytic metastases really well. If you can't get the MRI and you have the sclerotic metastases, the bone scans can be really helpful. And then, like I said, the radiographs are very helpful there's a very defined scoring system on the risk of fracture if you happen to have metastases in your arm or leg bones.
Thank you so much for explaining that. Dr. Chandrasekharan, there's a lot of concern about what causes neuroendocrine tumors or cancer. Can long-term use of proton pump inhibitors, Nexium, lansoprazole, Prevacid, cause neuroendocrine tumors or cancer?
So I think this is definitely relevant in terms of patients who have been diagnosed with what we refer to as gastric neuroendocrine tumors. But this is a very small subset of different other neuroendocrine sites. Majority are small intestine origin or pancreas origin or lung. So gastric neuroendocrine tumors have definitely increased probably in number, whether we are diagnosing them again because of the scopes we are doing more often and incidentally finding things. We used to think of them traditionally classified into type 1, 2, and 3, which is broadly one of the kind is when there is a tumor in the pancreas or the duodenum causing excessive gastrin, which in turn leads to these tumors inside the stomach area. Another kind where it's often associated with autoimmune pernicious anemia. So this is something where your stomach acid is not being made and those cells are kind of on an overdrive. So, and then the third kind, we used to call them sporadic, meaning we can't put them into type 1 or type 2, basically. But then recently, I think there's definitely been a recognition that there is these neuroendocrine tumors that we find in the stomach when we do the scopes without necessarily a very aggressive behavior that has been previously associated with the type 3. Oftentimes, these are multiple, like not a single area, but multiple neuroendocrine tumors. And majority of them are very slow growing, or what we refer to as a low grade or grade 1. I think this is an interesting entity. I think we're really overdue for reclassifying and renaming gastric neuroendocrine tumors. And that particular subset, the type that is maybe multiple low grade and often associated with long history of protonics or PPI use, is the only subset right now. Now, outside of that, to my knowledge, there's no connection of other neuroendocrine tumors with PPIs of any of the kind that's mentioned.
Thank you so much. Dr. Kunz, you talked about sequencing, about treatments, and that was really helpful. This is a common question. Are somatostatin analogs always necessary, also in the case of non-functional neuroendocrine tumors?
Great question. So we often will start with a somatostatin analog for tumor control in both patients who have hormone secretion and patients who do not. So for the patients who have hormone secretion, that's about 30 to 40% of patients. It's often a great first choice because it controls both the hormones and it controls growth of the cancer. For patients with non-functional or non-hormone secreting NETs, we can definitely consider somatostatin analogs, but we don't use it for hormone control. It's being used to slow down the growth of the cancer. So it's not required in everybody, but it's really a great early treatment, and in part because it's so well tolerated.
Yeah, thank you for that. Dr. Starr, there are a couple questions about supplements, and so I'll ask them together. One is, are electrolyte imbalances related to NETs such as muscle spasms? And if so, would magnesium supplements help? And then also generally, what vitamins or supplements are recommended for NETs, specifically lung NETs?
Yeah, this is kind of a tough area in that there is a lot out there, right? That you can read on the internet or a friend's, cousin's, brother's, wife told you that this, graviola seed, or sour sop, is helpful for this, that, and the other. And the way that I approach these questions with my patients is with an open mind, right? I don't know everything, and I am a Western trained physician, right? I'm a physician that kind of follows evidence-based, right, medicine. But there's eons before me in which medicine was practiced in villages, right? And medicine people, and these medicines worked. So I leave room for the things that I don't know. With that being said, I caution my patients on reading anecdotes or listening to podcasts in which there can be some predatory behavior online with people kind of purporting supplements and trying to push supplements because there's people are making money on the other end. There are no specific supplements that I typically recommend unless a patient has a deficiency in some vitamin, right? If a patient has iron deficiency, I will recommend iron. If a patient has a B12 deficiency, I'll recommend B12. If a patient has low vitamin D, I'll recommend vitamin D. The other supplements are, again, I'll usually incorporate my pharmacist, my clinical pharmacist, just to make sure there's no drug interactions with something that a patient's already on. But I'm very open-minded to saying if it's not going to hurt, go for it. But I'm not a naturalistic doctor. I don't know about all of these supplements. I wasn't formally trained in that regard. So I can't give specific advice, but I can help guide patients and at least make sure that whatever they're going to take is not going to be harmful.
Dr. Starr, thank you for that honest answer. I'm going to follow up with another common question that you probably get a lot, especially right now. What are your thoughts on taking ivermectin for neuroendocrine cancer?
Yeah, this is all definitely in the same vein. I get this question every day in clinic. And again, I approach it gently. And I'm not going to go on a soapbox, but I think that the ivermectin kind of evolved in the post-COVID. Hydroxychloroquine got popularized in the media, and people were saying, oh, you got to take hydroxychloroquine to either prevent COVID or treat COVID. And they did definitive studies that showed that it did nothing. And despite that, people still wanted to take it. Okay, that's their preference. The ivermectin got perpetuated mostly from a podcast called Joe Rogan, and there was a guest on named Mel Gibson. You may have known him, and he was talking about a family member or a friend who took ivermectin and their cancer essentially went away. There is no clinical data. There's, I think, one breast cancer study that was very preliminary. There's no clinical data that ivermectin has anti-cancer properties. That's clinical data. There is basic science data suggesting that ivermectin may interfere with growth pathways in cancer cells. I'll keep it kind of simplistic there, just to not go into the weeds. And the thing is with lab medicine, we've cured a lot of cancer in the lab that has not translated into humans because we're so complex and there's so much of an interplay between all of our systems and immune system, and our biology is so complex. So at this point in time, my kind of bottom line is ivermectin is not going to effectively treat your cancer. And I tell patients, I've had multiple patients take it. I don't prescribe it, and I have not seen it offer any benefit. So anecdotally, I've also not seen it do anything, right? Even though I've had a multitude of patients on it. So I can't with good conscience or with any level of confidence say, yes, you should take ivermectin. I would actually, again, I'm open-minded about it. I would probably say it is not worth pursuing outside of a clinical trial.
Thank you for your honest answer, Dr. Starr. Dr. Del Rivero, you are unique in that you're both endocrinologist and medical oncologist, and patients can get really confused as to what kind of doctor they should seek when they're looking for neuroendocrine cancer care. So I was wondering your perspective, if they should seek a neuroendocrinologist, medical oncologist, endocrinologist. How do they make sense of these ologists for a second opinion? And then specifically in the space of lung neuroendocrine.
Yes, also a very important question, Lisa. And yes, I can understand sometimes, trying to understand different aspects of their care can be sometimes confusing, especially if we are discussing about the neuroendocrine tumor and it's producing hormones. But one thing that we always discuss about neuroendocrine tumors is that it needs to be discussed with a multidisciplinary team. And we always have discussed this in different meetings, that the management of neuroendocrine tumors is not a one-size-fits-all. So we definitely need to discuss different aspects of their care with different specialties, and we have discussed that nuclear medicine, interventional radiology, surgery, medical oncologies, endocrinologies also is part of them, because there are certain syndromes related to neuroendocrine tumors that are managed by an endocrinologist. Like, for example, if a neuroendocrine tumor produces insulin, so we know that this excess of insulin causes a series of symptoms, very low blood glucose, and this very low blood glucose also causes a series of symptoms, and that's managed by different other drugs that are independently of the management of the neuroendocrine tumor itself, with the radioligand therapy, so with different systemic therapy. So some of these aspects is managed by an endocrinologist or the primary physician, which often a medical oncologist will need to involve an endocrinologist. But like I say, I think there is, in this field, is like we are a multidisciplinary type of cancer where we need the input from many different specialties in order to provide the best care. And that's how we usually discuss and advise that it's important to see somebody who knows neuroendocrine tumors, because that person will definitely then discuss in tumor board or discuss with different specialists to understand what makes the most sense. I can understand that sometimes the care can be fragmented, and that's something that us, as being in the field, is something that I feel we need to do better in that aspect, that we need to kind of come together and in order to benefit our patients. Sometimes we have patients who aren't not necessarily in an academic center, but they're more what we call in the community, seen by private physicians, and sometimes it's difficult to get access to different specialties. But that said, one thing that I always talk to patients is education. Knowledge is power. Try to educate patients about the different aspects of neuroendocrine tumors, being part of support groups, listen to all of the educational aspects that we have, like we have here with Neuroendocrine Cancer Foundation and others. I think it's important to keep yourself educated, to understand about your symptoms, understand about your disease. And that way, we can then all together provide the care that is needed. But I can understand that I do feel like we need the inputs from different specialties. Like I say, it's not like one size fits all. And that's an aspect that we all together need to work as well to provide the best care. I don't know if that answered the questions. And I think that there is an aspect that we need to understand how we can help those patients that are isolated, that are not necessarily in academic center, how we can help them. And that's something that I think as an organization, as also in the field, we need to work and do better on that.
Yeah, a work in progress. Thank you so much. Dr. Kunz, let's talk a little bit about neuroendocrine cancer that people don't know where the primary it originates from. So this person in particular asks, my net cancer origin is unknown and has metastasized to my liver. Would a colonoscopy determine whether it began in the GI tract? Why or why not?
So we still, despite having excellent imaging, including Dotatate PET scans, sometimes we'll come across patients who have a primary that we cannot determine where it started. And that's probably less now because our imaging is better, but it still occurs. When that does happen, we can sometimes consider both upper and lower endoscopy. So an upper endoscopy is called an EGD, and a lower endoscopy is called a colonoscopy. However, they do not cover the entire GI tract. So an upper endoscopy goes down into the stomach and into the first part of the small intestine called the duodenum. And a colonoscopy can go all the way through the colon to the cecum and something called the terminal ileum. That's right where the colon and the small intestine connect. And so if your NET originates in any of those areas that are covered, it could be found by an endoscopy. However, there's a big portion of the small intestine that cannot be reached by standard endoscopy.
I'm going to follow that up to ask, what about lung? What if it's not in the GI tract? How would you determine if it's in the lung or primary in the lung?
So again, I think back to PET scans, and Dr. Chen, I'm sure, covered this in some of her talk. I think with the advent and widespread use of either copper-64 or gallium-68 PET scans, the resolution is so much better, and we often will find small primaries that we cannot see on an MRI or a CT scan. So I would say that that has helped us considerably, and a lung NET could in fact be determined or found using a DOTA PET scan.
Thank you so much. Dr. Chen, I'm going to go to you specifically about the DOTA PET scans. When do you need to stop lanreotide or octreotide prior to copper or gallium-68 PET scan?
That's a great question. And there have been several studies looking at that, because the thought is the somatostatin analogs look just like dotatate, and so they will bind at the same receptor site. And the concern is that if you give the somatostatin analog, it will block the uptake at the tumor site and then make your dotatate PET scan essentially useless, because then you wouldn't be able to see those tumor sites. There have been at least 3 publications that I know that have looked at the timing of somatostatin analogs relative to when the dotatate PET scan was performed. And in all of them, it actually turned out they increased the amount of uptake we saw in the tumors because they decreased that background. So related to that pseudoprogression phenomenon that I was talking about before, in my talk, it tends to, the somatostatin analogs tend to decrease the amount of background activity. And actually, in one of those papers, one of them actually suggested that maybe we should be considering somatostatin analogs prior to giving PRRT to increase the amount of drug to the tumors. I think the cost of designing a study to test that well is probably too expensive, and I don't think anyone has the appetite probably to fund that at this moment. But generally, for our center, at least, we made the decision based on that data and based on our experience in the cases that we review in our neuroendocrine tumor board. We decided not to institute a firm timeline when you had to stop your somatostatin analog before a dotatate PET scan, because it seems that more often than not, it actually increases the sensitivity of the dotatate PET scan if you give it earlier than, say, like, if you're getting them every month, if you do the dotatate PET scan right after that monthly injection, or if you're on short-acting analogs. It doesn't seem to hamper our ability to see what we need to see on the PET scan. For PRRT, we still stick with the recommendation that we wait until you're about due for your next monthly injection, and we will give the PRRT prior to that. Again, because we don't have the data and we don't want to interfere with the outcome of the treatment. But it's an area that would be interesting to explore.
Thank you. Very common questions. Dr. Chandrasekharan, this question comes up a lot and a source of anxiety for many patients. Do NET metastases in the liver, can they be a source of metastasis? I've been told both, that they do and that they don't metastasize. Which is it?
Maybe tackling that with another question about even the primary, whether an intact primary tumor, meaning if your primary tumor was in the small bowel, and we leave it in, does it continue to kind of send off those cancer cells in other areas besides what's already there, right? I mean, I guess it's, in a way, these two questions are often asked. And I think cancer progression or spread is a very complex mechanism. The construct we have, we use to explain it is through the blood, through the lymph, and kind of the simplistic fluid-based progression or spread. But probably there's more than that. Because whatever the site of the primary is, wherever it started, once it's found a portal to get to another organ or location, which we refer to as a stage 4, it probably has favorable factors also at the organ where the cancer establishes, for example, the liver or the bone. And there's an interplay between what I guess we can call the host organ versus the cancer cell. So that simplistically, I think we try to think of it as a blood and a lymph flow, but probably there's a very orchestrated signaling that is still probably very not well understood by us to say, listen, this is how it spreads, right? It's not a linear model like how we think, oh, it spreads here, so then it's going to spread to the next step. And I think that's another thing that people ask. So just because it's in my lung, is it going to show up in my bone? Is it a bad thing? Or is it going to show up in another area? Is it bad when it gets to this spot versus that spot? And the honest answer is we don't know, right? For some patients, it will never go anywhere but the liver. For some, it will only go to the peritoneum or the belly cavity. For some, it seems to be very bone dominant in presentation, which we do know somewhat of an aggressive subtype in some people. So we truly don't understand how all these signalings happen in one person versus another person. So with that background, the question of, just because it's there, is it going to spread to the places? No, I don't think we have any such studies or anything that we can demonstrate that. Because unfortunately, when I used to be in Iowa, we say the cows that left the barn, they left the barn, right? So then it's hard to kind of rein them in that situation by just taking the primary area out or that particular liver spot or something out. So it doesn't really have any merit to, in my opinion, to take out the liver just because we want further cancer spread. Now, we do that for other reasons. We do operate and do some things for many other reasons in this cancer. But at least from an oncologist perspective, that's not to change the course of this path the cancer may take.
Thank you so much. Dr. Del Rivero, I mean, you're an expert when it comes to functional tumors, and you mentioned just now about insulinomas and such. So if the patient's primary is unknown and they have a functional tumor, does the type of functional tumor, for example, gastrinoma, insulinoma, give a hint as a likely primary tumor location? And if so, can the treatment choices and likely outcomes be based on this hunch?
Yeah, Lisa, no, thank you. And yes, it's a very important questions about understanding the symptoms related to hormone excess and how it happened and what new type of neuroendocrine tumors. So, and just to describe between pancreas neuroendocrine tumor, small bowel neuroendocrine tumors, and lung neuroendocrine tumors. For pancreas neuroendocrine tumors, up to 30% or so tumors can be functional. And what hormones the tumor produces, it can be a series of hormones between insulin. So insulin is responsible for regulate the glucose in the body. So excess of insulin lowers the blood glucose. So even with very small tumors related to an insulin-producing neuroendocrine tumors, patients are going to have symptoms. So that's the reason that very often insulinomas recognized earlier, just because the symptoms related to the excess of insulin. And those symptoms are very characteristic, low blood glucose, and all the symptoms related to low blood glucose, like sweating, dizziness, that they can only be normalized with having a very high glucose meal. Usually the glucose is rather less than 50. So that's kind of like very characteristic of the insulinoma. And also in those aspects, we need to do a series of hormonal evaluation in order to confirm. The same with the gastrinoma. Gastrinoma is excess of gastrin, and gastrin is responsible to produce acid in the stomach. So the excess of acid in the stomach can cause what we call a peptic ulcer disease, and that can cause symptoms related to that. It can cause ulcers, in some patients even it can perforate because of this excess of acids. It can cause diarrhea. So there are very specific symptoms related to that. And the same with glucagonoma. So glucagon is responsible for the metabolism of amino acids in the body. It can also suppress the insulin secretion. So if those patients has high blood glucose, they can also have very specific rashes in the body. So all of that, depending on what the hormone the neuroendocrine tumor produces, there are very specific symptoms. In most cases, especially with insulinoma, because of that, it can be diagnosed earlier. Now, talking about small bowel neuroendocrine tumors, we discussed earlier, it produces excess of serotonin. So the excess of serotonin is responsible for the carcinoid syndrome. I'm sure you heard throughout the meeting today about the different symptoms and how to treat it. And there are very specific symptoms related to that. Lung neuroendocrine tumors can also produce serotonin. And that's not in every patient. It's less common than small bowel neuroendocrine tumors, but that can also happen. One other hormone that happened in patients with low neuroendocrine tumors, and about 30 or 40% of patients with low neuroendocrine tumors, is the excess of cortisol. So cortisol is also an important hormone, and we discussed earlier is your fight and flight response hormone. And so this excess of cortisol has very specific symptoms related to that, like weight gain, high blood pressure. They have very specific skin characteristics that in some situations, sometimes patients doesn't notice that. And sometimes in cases that when it's diagnosed, it's kind of like in the later stage, but I think it's important to recognize the different symptoms. And I think going back to the question was, can you diagnose based on symptoms? Yes, because depending on what the hormone, the neuroendocrine tumor produces, it has very specific symptoms. And based on that, we can certainly work for that specific hormones that we think the neuroendocrine tumor is producing to make the diagnosis.
Thank you, Dr. Del Rivero. Dr. Kunz, I wanted to ask you about a sensitive topic. What is the impact of neuroendocrine cancer over sparing pelvic surgery, somatostatin analogs, liver-directed therapy, possibly PRRT on fertility?
So also an excellent question. So when we see patients who are of childbearing age, we will talk about fertility preservation, in particular if they will be starting treatments that we think pose a greater risk to either sperm or eggs. And these include things like chemotherapy, radioligand therapy. And I think, sadly, the field of neuroendocrine tumors has not been untouched by seeing more patients with early onset cancers. I think patients under the age of 50, 45, I'm certainly seeing more of. And so this has to become part of our routine conversation. And so in general, somatostatin analogs don't pose a greater risk of fertility, but I think we should broadly be having those conversations at time of diagnosis.
So important. Thank you for acknowledging that. Dr. Chen, is a Dotatate PET scan immediately after PRRT useful for evaluating treatment effectiveness, or is it mainly used for confirming the radiotracer uptake and distribution? And then how long should someone wait after PRRT to have that follow-up Dotatate scan to assess the tumor response?
Thanks. Yes, that is a very common question as well. How do we best use Dotatate scans in the context of PRRT? So when you finish PRRT, the way the radiation causes damage to your tumor cells, it can also cause inflammation and cause like a temporary increase in growth of those tumors before they shrink. So if you do a Dotatate PET a little too early, or even a CT scan a little too early, the tumors can look bigger and a little scarier before they shrink. So we tend to not use Dotatate PET right after the last cycle of PRRT. I think generally most centers, I believe now, are waiting 3 months. Our center for sure is waiting at least 3 months before we get a Dotatate PET scan to determine whether there has been any progression, or that's our first look at whether how well the tumor has responded to PRRT. In addition, so the uptake itself, while it does tell us where the tumor sites are, it can also be a phenotyping tool. So you could also rely on just the CT alone and rely on RECIST, like standard anatomic assessments of response. The challenge will always be those sites like the bones, where sometimes you can't see the sites very well unless you get the Dotatate PET. So generally we wait until later.
That's helpful to highlight the importance of waiting until later. I'm going to ask this last question to Dr. Chandrasekharan before handing it over to the second group. And this is a sensitive question, but something that I think we should talk about. Any suggestions or recommendations or resources to patients and family in the situation of advanced disease with neuroendocrine cancer when treatment is no longer working and acceptance has been reached?
Again, it's something we don't discuss definitely even in, I think, people who see a lot of volume of neuroendocrine tumors. Patients are always unfortunately told, oh, you have a slow growing cancer. Don't worry about it. You're not going to die from this cancer. And this thought is implanted like from the time of diagnosis. And the reality, unfortunately, is, as Dr. Kunz said, it is a cancer. And if you're otherwise healthy with no other medical problems, there are situations in the future where you're going to be where the cancer becomes the cause of the person to pass away. And I think the other what's different about the cancer compared to other cancers is, again, this prognostication is so difficult. Even for clinicians who've been doing this for decades, probably it's a hard question to know what will happen, when will it happen, or when this point is so reached. And there is no research, again, on the timing of integrating palliative care. I think there is some research in other cancers, for example, like lung cancer, There are studies, this could be predating the immunotherapy era, but even regardless, I think it's very relevant that patients who have palliative care involvement early on at the time of diagnosis in general have a better quality of life, and sometimes maybe suggestion of increased survival time as well, which is incredible. And no such literature exists in neuroendocrine tumor situation, because I think that, again, the varied presentation, and the duration of the treatments that somebody's on prior to a situation. In terms of resources, I think just remember that it doesn't have to be like a one-way street, or it doesn't have to be only the clinician suggesting it. Palliative care for me isn't really about any time along the way for any kind of a help you need with the team. So even the clinicians may get a help from the palliative care team for managing symptoms. It's not a bad thing to bring up palliative care. I think that's the first thing to realize. Palliative care in the different setting may mean also just supportive care for better quality of life. And in the context of when a point of where tumor treatments are not working and the patient is affected comes around, I think your oncology team or your neuroendocrine team and your local resource are definitely the best place to start in your institution or your cancer center, the palliative care team. I think just like everything else, this also needs a longitudinal relationship. So I think early onset or early integration, the question is, where do you define early is, like I said, unclear, not maybe a diagnosis, because you could be looking at years of palliative care. But I think when a person or a team recognizes that there are maybe limited treatment options, or the impact of the cancer is getting to be higher on the person in terms of quality of life, that could be at least a good timing for thinking about integrating these services. And I would always recommend for palliative care, especially local resources, because this needs a lot of hands-on management and interaction, knowing the patients and the care team's preferences, communication between all these teams for the best effective symptom management, as well as support physically, mentally, and psychosocially, as well as spiritually.
Thank you for that really thoughtful answer. It's a whole team approach, and thank you all for being part of that team. Thank you, Drs. Chandrasekharan, Chen, Del Rivero, Kunz, Starr, for your really thoughtful and sensitive answers, honest answers, and for all you do on behalf of the neuroendocrine cancer community. I'm going to now hand it over to Josh Mailman, who will lead the second part of the question and answer session.
Well, good afternoon. I just want to recognize to everyone who's out there. We'll go hopefully a little fast here, but we'll see what goes on. I think about this, Dr. Thor, you did a session on clinical trials today. A lot of questions about, certainly we have a plethora of PRRT trials going on, whether it's an alpha trial or a beta trial. And so this question is for a patient who's progressed on a somatostatin analog, should they consider an alpha trial versus going on the standard of care Lutathera as a next step? But also, I think I'll broaden that question as well to, how do you decide where to put people on clinical trials? And, one of the challenges for patients is also going on a first-line trial, which we're starting to see more of. And how do you look at that?
So excellent question. So I think the first step is to just make sure that the trial is really the right trial for you. It's feasible, it works logistically, and it makes sense. So if you have a good trial, be it the first line trial or later line trials, if you have, or your center has opened the trial, it probably is a good trial. There's a reason we brought it in. And so then you have to go through the uncertainties of being on a trial, the risks that sometimes are somewhat less well known than with standard therapy. And then at the end of the day, we've got to make a decision together. Is this something you want to do? And as for the alpha versus beta, so I will tell my patients that we don't have a lot of information on alpha particle therapy upfront. So in someone who's never had radioligand therapy or PRRT-like therapy, we have really good data on lutetium. We don't have a whole lot of data on alpha particle therapy. And some of them, as you may have heard, have been associated with some unpleasant side effects, including kidney problems and esophageal or swallowing problems. So I think you just have to be really upfront with your patients that yes, alpha it's a new shiny shiny, exciting thing. I think it's going to be really effective. I think it's going to be safe, but we also have a really good standard option in the form of lutetium dotatate. So all of these things are just things we got to discuss, and then at the end of the day, we'll have to make a decision together that the patient and their families are comfortable with.
I guess I would just add that, part of the question was, should you jump to a trial on like progression after an SSA? And I would not skip lines of therapy just because there's a trial out there. If someone gets referred to me for liver therapy, I have right now 4 liver therapy trials in the net space at my place. So I might offer you a liver therapy trial, but I would not say, oh, you should go do our alpha trial. How cool. If systemic therapy is not the right thing for you. So just because there's a trial out there, you have to, I think Thor is very correct. Like you have to say, is this the right thing for me now? Or is there some more standard therapy that really is the appropriate thing for my disease right now? And I'll keep that trial on the back burner because maybe that'd be more appropriate later. Does that make sense?
Of course. And Dr. Soulen, the next question really is going to you,
Okay.
which was, you talked about IR trials, but something that came rather quickly without much IR trials is histotripsy. And do we have more information about histotripsy? Because as Dr. Thor said earlier, the bright and shiny thing that's currently available, that was the bright and shiny thing probably 2 years ago. Is it still bright and shiny? Have we learned more? Are there new trials that you're running or that are part of?
Yeah, so histotripsy is an ablative technique that uses focused ultrasound to obliterate one or more small lesions in the liver. It's rarely appropriate in the setting of neuroendocrine tumors because they're mostly patients with many liver lesions. So, I mean, we do more standard forms of ablation, microwave, cryo, et cetera, as well. But we don't have much occasion to do that in neuroendocrine tumors. So given the generally limited role of ablation, period, as a strategy in NETs, I don't think there's much of a role. And, histotripsy has been excessively publicized in the lay press, shall we say, for its supposedly immune stimulating properties, which are, as was alluded to in the previous session, things that happen in cells and mice, but not in people. So, and what is less well known, but becoming more obvious now, is there have been a number of extremely serious complications and adverse events in the setting of histotripsy, including widespread dissemination of disease, kidney failure, injury to surrounding organs like bowel. So it's not a procedure that I generally recommend for patients, and nor do we offer it at our institution, although there are certainly plenty of other institutions in my general area that do.
With that going forward, I'm going to ask a kind of stay on the clinical trial front, but also other therapies that are available. I get this one a lot, not necessarily for lung cancer, but are there advancements in treatment in Europe or other parts of the world that are promising that we don't have here? If so, can we find out about them? And, I think of this also in PRRT, but in that realm, where are we in having pretty much the same treatments available globally?
Yeah, I'm happy to start off on this question. I think that increasingly the neuroendocrine community is more international, more global. There are studies that are, particularly when industry sponsored, occurring in multiple centers across the world. So I think we're on the same page and even doing the same studies. I think you will find, and this is even true within the United States, that there are some studies that are open at certain centers. But I think the questions that are being answered are quite similar. Some of the common questions are being asked both in the US and Europe. And hopefully we can combine what we learn in both areas to kind of get an answer that will help everyone. But yes, there are some trials that are going on in Europe that are not going on here in the US.
I definitely agree with Dr. Chen. I think we've come a long way compared to maybe like 30 years ago when PRRT was not available in the US and a lot of patients had to go to European centers. I do want to highlight, in addition to what Dr. Chen said, advocacy organizations like NCF play a big role in helping patients identify clinical trials. And I always encourage my patients to explore clinical trial options on their own. Clinicaltrials.gov, all you need is neuroendocrine cancer and the name of the city where you're located to see if there are any clinical trials available in that location or around that location. And then seek help from your multidisciplinary neuroendocrine tumor team and also patient advocates that you're working with to identify a clinical trial that you might be eligible for, and especially if in the context of your diagnosis and current clinical scenario, if that would be appropriate. I think relying on patient advocacy and your multidisciplinary team can really help you identify those clinical trials beforehand.
And Dr. Thor, I know that you highlighted the Ancora tool that we use for neuroendocrine tumors. We actually have been comparing it to using upfront Claude or ChatGPT, and it works rather favorably.
That's
thankfully.
actually really great to hear, because even for us who live and breathe this stuff with clinical trials, even the NCI or National Cancer Institute website can be hard to navigate. So you may, if you put in a generic term like neuroendocrine, you may end up with like 100 different clinical trials, and maybe one or two of them apply to your situation. That's why we need AI-driven tools like Ancora. And I haven't actually played with Plot or the others, but I probably should. But I've been very pleased with the performance of Ancora.
Yeah, I think one of the challenges has been the metadata that gets tagged to your trials, and sarcomas get tagged to, in the NIH world, get tagged to neuroendocrine tumors. So just typing in neuroendocrine tumors will get you 3 times as many things that aren't neuroendocrine tumors. But that's for another whole presentation. Dr. Chen, you were the primary investigator on cabozantinib. If you have a patient that already is working with or has symptoms of diarrhea, fatigue, and weight loss, and potentially kidney disease, do you put them on cabo? And if so, how do you mitigate those symptoms?
Yeah, these are great questions, Josh. I think as we make decisions about what sort of systemic therapy to offer or to recommend, I think we do have to take into account a lot of factors, including baseline symptoms and other comorbidities. So we can select various treatments based on what we think people may be able to tolerate or benefit from most. When it comes to the specific example that you mentioned, there are some patients who may have underlying fatigue and diarrhea, where we do have to be careful if we're going to be using cabozantinib. We may even start out with a lower dose. The usual starting dose of cabozantinib is 60 milligrams a day. Sometimes we can start with 40 milligrams, or even if we're really concerned, go lower and escalate if tolerated. But I think that's where we have to be cautious with dosing and also close monitoring once people start treatment, even just checking in, for that first week and then 2 weeks and going from there.
I think you would be the expert on this, being that you were the PI on the trial as well. So one of the questions that has come up a lot in the last year as we've talked about GLP-1s, I know that we have seen back to mouse models and things in the petri dish that we've seen some negative results with tumors that overexpress GLP-1. I know that it isn't a large percentage of tumors that overexpress GLP-1, but how are you advising your patients who are looking at GLP-1s?
Yeah, I just had a patient this week who's got really poorly controlled diabetes. We've been struggling with this for years. He's also on an SSA, and finally his endocrinologist is like begging me to allow him to start Ozempic. So I just did as Thor said, AI is great, did a deep dive into Copilot in the office. And there was one large study of between 500 and 600 neuroendocrine tumor patients, and only 7% of those patients, their tumors express the GLP-1 receptor, which suggests that over 90% of patients don't, and therefore it would be fine to be on a GLP-1. And how do you know? Well, if you've had a biopsy and someone has your tissue, it can be stained for the receptor. So, if you can get your pathologist to check, you can even find out whether your tumor has a GLP-1 receptor or not. And if it doesn't, you should be okay. Now, of course, you have to have that state available. My hospital does not. So actually, my pathologist can't answer that question for me. Also, the interesting thing that came out of this several hundred patient study was that expression of the GLP-1 receptor was limited to certain types of neuroendocrine tumors. So, for example, not small bowel. So if you're a small bowel neuroendocrine tumor, you probably don't have the receptor, and it's probably fine for you to be on, Ozempic or Wegovy. So I'll just put that out there. That's as much as I learned this week about it. But that's kind of how we're approaching it now, is essentially going to our pathologists and seeing what we can do to get them to bring in the IHC stain for GLP-1 receptors so we can start. Because as Josh said, if a third of the population's on it, why don't we just screen the patients and see whether it's an issue for them or not? And I'm happy to see what Thor or other people have to say about it.
I actually might hand this over to Dr. Grewal. And it's not like I'm trying to get out of this question. I believe he may have submitted something earlier today on this.
Yeah, I agree with what Dr. Soulen said, but one thing that's important to recognize is these are not all just one agent. There's, based on the receptors that they target, for example, Ozempic is a GLP-1 receptor agonist, but there's another agent, tirzepatide, which targets GLP-1 and also GIPR. And while we don't have a lot of reliable data for GIPR, the expression of GIPR is reasonably high in small bowel neuroendocrine tumors. And so those agents should be avoided for the most part in patients with small bowel neuroendocrine tumors. Now, when it comes to testing tumors for GLP-1R or GIPR, we really don't know what that really means in terms of the oncologic risk associated with these agents. And also, we don't know if the risk is different in patients that have an underlying genetic syndrome, in which case we tend to avoid. There's also a black box warning for patients with MEN1 or medullary thyroid carcinoma or familial history of medullary thyroid carcinoma. So I think broadly, we have some preclinical data that shows that there is a risk in patients that have GLP-1 receptor expression, but there is also some population-based data that shows that the risk might not be there. I think it really boils down to understanding the indication for the agent. In some patients, it may just be weight loss. In some patients, there's comorbid type 2 diabetes where it is being used for the benefit with glucose control or also other cardiometabolic benefits. So working with an endocrinologist or cardiologist who may have started this agent and then understanding the underlying disease risk, like does the patient have progressive disease? What kind of symptoms is a patient dealing with? A lot of our patients with neuroendocrine tumors may have a lot of weight loss ongoing, diarrhea, may have poor nutritional status, and those patients we really want to avoid. But other patients who are relatively fitter, don't have a lot of those symptoms where we worry about overlapping toxicities, don't have rapidly progressive disease, and we've established that there are clear cardiometabolic risk factors that would necessitate them being on these agents, I think it is relatively safer to use, but it has to be a nuanced discussion and a multidisciplinary discussion.
Yeah, the only thing I'd like to add to that is that in patients with neuroendocrine tumors who are expected to have a long life expectancy, and they have these the cardiometabolic risk factors that Dr. Grewal was mentioning, the potential for benefits from these drugs may actually far outweigh any risk that right now is mostly theoretical. And but that said, if you have patients on these drugs, what I say, follow closely, use the lowest possible dose, and use it for the right indications.
I think the following closely part is, like, for instance, the patient I had just this week. I mean, I've been managing him for several years. He's on semi-annual surveillance. But I said, if you start a GLP-1, we're going to go to every 3 month scans on you again until we, for a year, until we know that your previously stable tumor doesn't take off on us. So the surveillance part is very important if you're going to try the drug.
I couldn't agree with you more. So this is a question from a patient who had a PNET that was metastatic to the liver, had chemotherapy and surgery, no evidence of disease. So this is basically, I've had surgery and I've had pre or post chemotherapy and now I'm NED. What are our statistics on surgery? I know we don't have a surgeon on here, but from chemotherapy agents and surgery, getting to that point of having no evidence of disease to what percentage of them will show up again?
I can start off on this answer, Josh. I think a lot of the data that has been published related to liver metastases and resection of liver metastases does suggest that there's a very high risk of recurrence. Even if you can resect everything, there's almost a like 90+% chance that there may be some recurrence in the future. So, I think many of us don't necessarily think of surgery as curative because those rates of recurrence are so high, but there may be a very big or important benefit for longer term outcomes and increasing survival in the longer term. So I think that this approach that this patient went through, where there was clearly multidisciplinary evaluation to kind of think through the role of systemic therapy and surgery, is critical for everybody, because we do, even if we can't necessarily cure everybody, want to offer the best outcome possible.
I would agree with that, and that's why it's so important that when we recommend the liver resection or any liver-directed therapy, that it's not done with curative intent. Something will most likely show up in the next few years. And they will just point out a small study. This was 10 patients. It's from, I believe, from Norway. They looked at the uninvolved liver that came out with a liver surgery. So there's a tumor that came out, and then there was a piece of seemingly normal liver. So they looked really carefully at that. And then all 10 patients they looked at, there were tiny little clusters of neuroendocrine tumor cells sort of in the liver. But some of them, and they looked to see how did these people do over time. And after following them for like 4 or 5 years, 40% of them had not yet shown any tumor growth. So even if they are there in very small numbers and in very small clusters, they may not need any treatment for a long time. But you may have set the clock back by liver-directed therapy. And I would actually like to kick that over to Dr. Soulen to say, what about like if you have liver disease and there are only a few little spots growing, what is the role of ablating those so you can sort of continue to observe or continue the line of therapy you're on?
Yeah, so I get asked that question a lot. You may have someone who has, for example, maybe they've been on systemic therapy, which actually often works quite well outside the liver and less well in the liver. And maybe there's 2 or 3 liver lesions that are practically, we call that oligoprogression, where everything else is stable, but just the liver is kind of perking up a little bit. And you ask, well, could you do something just for that? And the answer is, well, we can. Should we? Good question. But we often get asked to do it. And so I'll discuss that with the patient. In other types of cancer, treatment of oligometastasis and oligoprogression seems to be beneficial. So we definitely do it. And also you have the scenario where maybe that's all they have. Maybe they just have 2 or 3 little liver lesions. And you say, well, can you just ablate them? And I'll say, sure, right? I mean, I would resect them. So if you could ablate them, why not? But I tell them the same thing you just said, like, we're going to keep scanning you. Like the risk of recurrence is constant for at least 10 years. And even if I get rid of these spots today, you still need surveillance, maybe less and less often as time goes by. But, something may pop up again. And if we catch it early enough, maybe we can ablate that. And then we have these rogue lesions where they have multiple liver lesions and just one isn't behaving. And so that is a not terribly unusual scenario. Well, I get asked by a medical oncologist, well, is there something you could do? Like, I know there's 10 lesions, but could you just treat this one? Which seems a little odd. But in fact, that's the one that's misbehaving. So one thing, we always biopsy it because if one lesion is misbehaving, it's quite possible there's been a grade transformation or something unusual is going on there. So, but we'll definitely biopsy and then do a directed therapy to just that one lesion and leave the rest of the liver alone until it needs something. So I hope that answers your question.
Also, I would like to add, piggybacking off of what Dr. Halfdanarson said, I think the risk is practically 100% is what I tell my patients. It's a matter of like the biology, which will decide when that recurrence happens. And I also wanted to mention in patients with pancreatic NETs, where we see a couple of liver lesions that can be surgically resected and the patient can be rendered NED, once we have the results of SWOG 2104 available, it'll be nice to see if we can extrapolate from that and educate our patients if adjuvant CAPTEM might meaningfully alter that risk of recurrence.
Can you quickly explain 2104 to the audience?
Yes, so this is a clinical trial, phase 2 randomized, that is looking at adjuvant chemotherapy with capecitabine and temozolomide, 3 months versus observation, which is currently considered the standard of care. This only applies to patients that have a high-risk pancreatic neuroendocrine tumor that has been resected, And the risk is determined based on a score called US NET score or ZADI score. So we're trying to see if in patients with this high-risk disease, if adjuvant chemotherapy with capecitabine and temozolomide, which is a standard of care chemotherapy normally used in patients with unresectable or advanced disease, if giving this as an adjuvant, as an after resection therapy, would that modify the risk of recurrence meaningfully? Dr. Heloisa Soares is the national PI on the study.
Thank you for bringing up that trial as well. There's confusion often about whether lanreotide and octreotide are chemotherapy or not, but this is a patient who's been on everolimus and had progression and then moved on to, it looks like they've had everolimus as a first-line therapy and second-line therapy, had octreotide and lanreotide, and none of these have worked so far. Lutathera has been their best option so far. Does this mean that chemotype therapies have a low probability on working in this type of cancer? Have we gained any knowledge of when CAPE-10 might work better than others, or when everolimus might work better, or any markers or tests that we are helping us determine where to go next when something doesn't seem to be holding a patient stable?
Yeah, so I think the most important thing is to know where this cancer originated from, because the two most common of these, pancreatic and small intestinal, respond very different to treatment. So the small intestinals do not respond at all or rarely to capecitabine temozolomide, also known as CAPE-10, while the pancreatic neurotumors look just the same in the microscope, can respond in 40 to 60 or even 70% of patients, depending on which study you look at. So that's the first thing. And then you have to look at the tumor grade and the expression of somatostatin receptors, because not all of them are created equal in that sense. Some of the pancreatic neuroendocrine tumors may not have a lot of somatostatin receptors, and you wouldn't necessarily expect that octreotide or lanreotide or even PRRT would work for those patients. You have to know that too. And then in terms of octreotide and lanreotide, although I consider them equally effective drugs, one of them is a little bit more challenging to inject. So the octreotide has to be injected into a muscle, while the lanreotide is injected under skin. And sometimes those injections are just not placed in the right location. So it's and then everyone is a little different in terms of this. I tell my patients the fact that you didn't have a response to treatment A doesn't not necessarily mean you want to respond to treatment B and treatment C. I have seen patients not respond to A and B, but have a great response to treatment C, which I didn't really expect. So hard to predict. And then I wonder if my colleagues have any additional thoughts on that.
I was going to say, I completely agree with Thor. I think we don't really have great predictive markers. The ones that we will use in clinical practice are the ones that Thor mentioned: primary tumor site, grade, somatostatin receptor expression. There has been, and I think there continues to be work done trying to identify predictors of treatment benefit, because as we have more treatments that become available, it's nice to know which ones may be most likely to work for certain patients. When it comes to temozolomide, people have investigated whether expression or presence of a DNA repair enzyme, MGMT, is associated with response. And there's some suggestion that it might be loss of that enzyme, loss of activity of that enzyme might be associated with benefit, but it hasn't really been confirmed. So we're not using that in clinical practice, but I think it's important for us to continue to try to explore markers that can help us to better select treatments in the future.
And it's also important to realize that the context very much matters. So, for example, if you're using chemotherapy as a systemic therapy, as Thor described, it may work better in pancreatic nets than in small bowel nets. If you're doing liver therapy, doesn't matter. Liver therapy works equally well whether you're a lung net, a PNET, or a small bowel net. So, if for some treatments cell origin may matter, and other treatments it doesn't. Similarly, like I use a lot of capecitabine, CAP-10 when I'm doing radioembolization as a radiosensitizer to make the radioembolization work better. And again, it doesn't matter, like the small bowel nets do just as well as the pancreas nets when I'm combining the chemotherapy with liver therapy. So, context matters, how it's being, each treatment's being used. And as Dr. Chan said predictive biomarkers, like we wish we had more of those. And one of the very interesting ones that just came out relatively recently from Memorial Sloan Kettering was actually a mutation that can be detected on biopsy. Two mutations, actually. One's called DAX and one's called ATRX. And if you have that, it predicts that you're going to be sensitive to radiation. So, for example, in a very small series from there, as well as in a bunch of laboratory studies, it was shown that tumors with that mutation were much more sensitive to radiation exposure and radioembolization. Now, whether that's true for PRRT as well, that hasn't been tested yet. But like knowing that would actually tip me toward a radiation-based therapy versus some other therapy. So we are making some progress in that area, but much more to be studied.
So any patient would be honored to have you as their oncologist or IR physician, but we know that 80% of patients are seen in a community setting and not seen by you, as much as I wish that weren't the case. How do you work with community oncologists, or how do you increase your catchment area or make sure that patients who live in more rural areas can have access to your knowledge, or that their oncologists and local healthcare providers?
I mean, I think it
Well,
alludes to the bigger question that we all address all the time, which is, if you're an endocrine tumor patient, you need access to a multidisciplinary team. Like you have to somehow get advice from a center of excellence. And depending upon where you live in the country, that may be an hour away or it might be 6 hours away. I mean, forget what I do, what we all do, getting the best treatment plan really depends upon access to some place that has an endocrine tumor board and an expert multidisciplinary team. And that's the challenge for all of us, is to get that out there. Now, if you have access to that, you don't have to go there to be treated. So, obviously, if you make a plan for chemotherapy, then you can find your local medical oncologist can almost certainly administer your chemotherapy or even your octreotide or lanreotide, right? Things like PRRT, you need some degree of specialization with a place that does nuclear medicine theranostics. But again, there are a lot of places that offer it that are not necessarily the neuroendocrine mothership. And for, liver-directed therapies like I do, I mean, these procedures are literally 50 years old, right? I mean, I was in junior high school when people started doing embolization of the liver, right? So as a technique, it's something that interventional radiologists in general broadly are trained in. So, even for my catchment area, which goes several hours in many directions, I will often tell people, okay, you need your liver embolized, and here's somebody in your community who does this. So, and so people can make the choice doing what they want to travel several hours to get treated, or do they want to go local? So, and we all try to do that in each, whether you're in Boston or Minnesota or Philadelphia, we try to get people access to care as conveniently as possible. But, it's certainly a challenge. I mean, one of the facts is that 85% of the counties in the United States don't have an interventional radiologist, right? So access to care outside of the heavy coastal concentrations and the major Midwest centers can be a challenge for people. But the procedures themselves, most people, if you have a competent, practitioner in your community, they can offer it to you.
Not from the sort of chemotherapy, medical oncology perspective, I tell my patients that when it comes to actually giving you the treatment, the chemotherapy or the targeted therapy, or even the PRRT, you're almost certainly going to get the same quality at home as you will with us. Where we can help the most is at the sort of decision point where something is happening, or a change needs to be done because of tumor growth or side effects or something like that. So the system I have with us is mostly that my patients go to their local community oncologist, and it's very, very important that you communicate clearly with them in whichever way what works for you, and make sure that yes, you are going to give your opinion, you are going to recommend that they get the treatment at home, but you also tell them when something happens, if something grows, if there's a side effect, you will be there for them. And what we need to figure out a little bit better is how to make that work a little bit better in real time, because as you know, complications don't come on a schedule. They just happen when they happen. And so you may have to get someone quickly in where you didn't really have an opening, and you have to get a little creative. So I think communication is really the key. But when it comes to procedures like Dr. Soulen does, then it's a little more challenging.
I do want to add, I certainly agree with my colleagues here. I often tell my patients it's not just about one person. It's not about me. It's about the team. It's about the multidisciplinary team. And every time there is a major decision that needs to be made or a recommendation that needs to be made, of course, it needs to involve our patient and their loved ones, but also it needs input from a multidisciplinary group, discussion in a multidisciplinary tumor board, which sometimes our colleagues in the community may not have access to. So it's really the multidisciplinary expertise for which patients should be, working with an expert team or a specialized net center. And it's not just clinicians like myself or a surgeon or interventional radiologist. It's also our pathology colleagues who review the slides and help us make an accurate diagnosis. So at very many levels, we can see the impact of working with a multidisciplinary team. And to answer the earlier question, Josh, how do we actually meaningfully engage with our colleagues? Of course, like, community outreach and interacting with our colleagues and making them well aware of what are the services or expertise available at our institution, but also through advocacy organizations, empowering patients to understand the impact and the importance of expert consultation or working with a multidisciplinary team through events such as this annual conference today, so they can request a consultation from or a referral from their local oncologist. I think these are all meaningful ways of engagement.
Yeah, I agree completely with everything that's been said. I think this is also where these virtual tumor boards can be helpful, where, even if somebody is hours away, sometimes even just having that information, inviting the local oncologist to join us at tumor board, just to be all at the same table is very helpful.
So I'm going to ask one last and final question to all of you, and it's going to have nothing to do with treatments. You all have been passionate here in this last 45 minutes. Every time I've seen you and worked with you in various different venues, you've been passionate about your work for neuroendocrine tumors and neuroendocrine tumor patients. I want to know, because you didn't have to take this route. You didn't have to take the route of taking care of NET patients. There are clearly other diseases that, whether they're more lucrative or easier to publish in, et cetera, what is it about NETs, or why your dedication to neuroendocrine tumors? And
I think, I've, as you mentioned, been doing this for almost a few decades now, and it has been pretty amazing to see the field evolve. I think it is exciting actually to have newer tools, newer questions, and even the community patients are engaged. My colleagues said the field keeps growing. So I do think it's just an exciting time, a lot of questions to try to answer together.
I would say, there's a phrase that a lot of my colleagues have used in the past, catching the net bug. I think it just happened. And the answer is if you ask me why, I would say, why not? I mean, there's no reason why anyone would not be interested in helping our patients. When you look at the impact that you can have in a space like this, it's just huge. Like Dr. Chan said, there's so many questions that remain unanswered. So the potential for impact is just huge. And I also want to say patient advocates like yourself, Josh, and others really make the field what it is, even from a physician's perspective. And I would say kudos to all the luminaries on this panel who've been doing such great work that younger colleagues like myself really felt that there's so many opportunities for growth, and hence I chose this path.
So in some ways, so I didn't find the nets, but they found me, and that you sort of fall into the wrong or the right crowd, and so I didn't plan on this. Actually, I wanted to be a hematologist, and then I just fell into the GI oncology, and then I was given a project on neuroendocrine tumors, on pancreatic neuroendocrine tumors to be specific. And when I was reading about this, I just realized how much is unknown still. And this is back in the octreotide and streptozotocin days, and that's pretty much the list of the drugs that we have, and the interferon. So, I just thought there's just so much more that can be done and needs to be done. And so that's sort of what sort of got me involved in this. And then we'll also say to the younger colleagues that, and those who are not necessarily on this call, it's also, I think, a very friendly crowd. It's a very collaborative crowd. So if you are a young professional oncologist or radiologist and you want to get into this, you will probably get to know a whole group of incredibly helpful and collaborative people. And it is truly becoming my other family. I'm just looking around to see if my wife's listening, and so and she's not.
Dr. Soulen, I'll end with you.
Well, like Thor, I did not find NETs. NET found me. I mean, I've been practicing for 35 years, and I do liver therapy for lots of cancers. I mean, liver cancer, colon cancer, but the reality is the NET patients live forever, right? So it's just ecological. All my non-NET patients basically succumb to their disease, and over the years, my clinic became completely taken over by all my NET patients. So the very first patient I ever chemoembolized when I came to Penn in 1991 was a NET patient, and he lived for 25 years. And one of the things I really enjoy about working in the NET population is you develop these very long longitudinal relationships with these patients you take care of for years, decades even. So I have many patients that I've been caring for 10 or 15 years now. And you get to know them, their families, you hear about their grandchildren, their dogs, et cetera, et cetera. So in that sense, it's a very rewarding area of practice because of these great relationships you develop with these people, as well as colleagues like the ones on the panel today who are really just a great group of people to work with. And as everyone else alluded to, it's also such an interesting field. Once it takes over your life, you realize there's so much going on. There's so many different types of NET tumors and NET patients, so many questions to answer. We have all these clinical trials going. It's so ripe for bringing students and residents into the field because there's so much going on. We just have a steady stream of trainees that we give projects to. We just started this week with our new crop of summer medical students who are all doing NET research with us. So it's just, at the clinical level, the research level, and the teaching level, it's a very rewarding field to be in. And it just, it charges my batteries. What can I say?
Well, I thank you all for being here today and for being here for us all these years and for years to come. And with that, I'm going to turn this back over to the studio. And so we'll turn that over now.